All right, welcome everyone to our next session in our Boosters and Beyond series. Thank you for coming back again. We did have some technical issues the past couple of weeks and getting that squared away. Again, we appreciate you all circling back with us to continue this very important topic of antipsychotic use within the nursing home setting. But before we get into that, I'd like to go through some housekeeping items. Next slide, please. So if you're not familiar with who we are, iPro holds the Medicare, federally funded Medicare QIO contract for the regions shown here. iPro helps support specifically in New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the iPro QIN-QIO. So if anyone asks if you're working with iPro or Health-Centric Advisors or Clarent, you say yes. Next slide, please. So just to give us all an update on COVID-19, we can see that the hospitalizations continue to trend down. We're at 56.4 million adults, individuals who have received the updated booster dose. Still lagging for the adults over 65 that receive the bivalent booster. I know COVID fatigue and COVID discussions continues in the nursing home setting. Important to note where, even in China, they're continuing to see more outbreaks and waves. So just because the public emergency has ended doesn't mean that COVID's going anywhere. With the latest variant, XBB strains remains the most dominant, with the 1.16 being the latest concern and having a name now as Arcturus. Next slide, please. Here's just a map about the new hospitalizations rate per 100,000 within the past week by county. As you can see, majority of the country is in a pretty low admission rate, but there are little blips across the country with higher rates. So just keep that in mind as we continue to work through the summer. Next slide, please. So at this point, I'd like to pass it over to Margie Giuliano, who is our esteemed speaker for today. Margie, could you just tell us a little bit about yourself and get started?
Sure. Thanks, Josh. So I'm a pharmacist, and right now I'm doing consulting work with iPro QIN-QIO on medication safety. So I'm going to get right into the talk today. Our learning objectives for today are to list the risks and benefits of the newer antipsychotic meds. We're going to compare side effects of the newer versus older antipsychotics, and we're going to describe any potential benefits of the newer versus the older antipsychotics. Next slide, please. So this slide is from the CDC, and it reflects the prevalence of antipsychotic drug use in nursing homes from second quarter 2011 through the fourth quarter of 2021. As you know, the inappropriate use of antipsychotic medications among older adults living with dementia residing in nursing homes has been a concerning practice that CMS and other regulators have tried to control for decades. As you can see in this slide, prior to 2012, the use of antipsychotic in long-stay residents in nursing homes was really around 24%. In 2012, CMS created the National Partnership to Improve Dementia Care in the Nursing Homes in recognition of the high prevalence of antipsychotic drug use. The goal was to reduce the overall use of antipsychotics in individuals with dementia due to the side effects and the fact that really there was no proven indication for dementia-associated behaviors. If you look at the data that we've got from 2012 through 2019, we see that there was a 40% reduction of antipsychotics and other psychotropic medications. However, we also see that starting in like 2019, 2020, there was an uptick in use, and it continues through the fourth quarter of 2021. Certainly COVID-19 act on this. Next slide, please. So the psychotropic drug use during COVID-19 was higher in the nursing homes due to the devastating impact that COVID-19 had on the long-term care resident population, especially for those with dementia. There was lack of family visitation, lower staffing levels, masking, certainly stress to the staff and to the residents with all the sickness and death. So there was really just a higher use of these psychotropics and antipsychotics during this time. Getting the numbers back to pre-pandemic levels has proven to be somewhat challenging. Next slide, please. So antipsychotics are used in the nursing homes to treat psychoses and diagnoses such as schizophrenia, Tourette's syndrome, bipolar disorder, and Huntington's disease. The prevalence of the use of antipsychotics doesn't necessarily align with the prevalence of residents with documented diagnoses. Dementia diagnoses are often associated with psychosis, paranoia, severe agitation, and other behaviors that are difficult to manage with the tools that we have in the long-term care setting. However, the urgency for reducing antipsychotic use for individuals with dementia is in part that antipsychotics have now been labeled with boxed warnings, which are previously referred to as black box warnings. These warnings state that elderly individuals with dementia-related symptoms have an increased risk of death if treated with antipsychotics. So certainly we want to use non-medication treatments prior to having to resort to antipsychotics. Next slide, please. So your medical provider or psychiatrist, if your facility has one, is really the person that's going to make the diagnosis. You can see individuals with dementia, now referred to as neurocognitive disorder, can sometimes be misdiagnosed with schizophrenia, especially again when you look at the signs and symptoms of each side by side, you can see where this might be a potential. Next slide, please. So what are antipsychotics? Generally speaking, antipsychotic drugs are used to treat, again, the symptoms of schizophrenia, bipolar disorder, and other psychoses. There are two classes of antipsychotics, the first generation or typical antipsychotics and the second generation or atypical antipsychotics. Both classes of antipsychotics work by blocking receptors for the neurotransmitter dopamine in the brain. Dopamine plays a role in many body functions, including memory, movement, motivation, mood, attention, and more. Dopamine aids in the passage of messages throughout the brain, so blocking dopamine reduces the flow of these messages, which can help to reduce some of the psychotic symptoms that are a result of high levels of dopamine in the brain. The second generation antipsychotics not only block dopamine, but they also block the neurotransmitter serotonin. Serotonin also carries messages between nerve cells in the brain and throughout your body. So serotonin plays a key role in such body functions as mood, sleep, digestion, nausea, wound healing, bone health, blood clotting, and sexual desire. Next slide, please. This is a list of the first generation or typical antipsychotics. They're primarily used again to treat the chemicals in the brain that relate to the symptoms of unclear, or disorganized, or unusual thoughts and behaviors. And they also help to improve motivation, lack of emotion, loss in ability to experience pleasure, be with others, etc. These drugs are not used as frequently as the newer antipsychotics in general, but that being said, if you have a resident that's admitted to your facility on one of these medications, let's say that you have a resident that's already been diagnosed with schizophrenia and they come in and they're stable on a drug like haloperidol, one's not going to really make any adjustments in this medication unless assessments would indicate otherwise. So currently in the long-term care setting, first generation antipsychotics are not used nearly as much as the second generation. We do see haloperidol used primarily. We see some use of it in residents that are on hospice. Next slide, please. So the most common side effects of the first generation medications are motor side effects, otherwise known as extrapyramidal side effects. They include dystonia or uncontrolled muscle contractions, ocular motor crisis, akathisia or restlessness, Parkinson-like symptoms, etc. If symptoms progress to late phase, these motor side effects will present as tardive dyskinesia, which is like these jerky or uncontrolled movements of the tongue, the face, and really of the entire body. When we're starting residents on these medications, it's really important to, watch and have them avoid activities that require mental alertness or coordination until we see how these medications affect them. There's certainly great potential for drowsiness and dizziness and sedation. So certainly we don't, we want to monitor them so there are no falls, etc. Monitoring is important when taking the first generation antipsychotics. Again, aside from monitoring for these motor symptoms and the tardive dyskinesias, we're going to also be monitoring for blood pressure, eye exam, kidney and liver monitoring as well. Next slide, please. So this is a list of the second generation or atypical antipsychotics. We most commonly see drugs like olanzapine, quetiapine, risperidone, and aripiprazole prescribed in the long-term care setting. The second generation antipsychotics, with the second generation antipsychotics, we also need to make sure that we're cautious when using these medications, of course, with older individuals. Individuals need to be cautious about doing activities, again, that require alertness until they know how the medication is going to affect them. This, again, is because of the drowsiness and dizziness that can occur. Individuals also have to be cautioned about rising slowly when sitting or lying down due to the potential for orthostatic hypotension. Providers may also have to adjust doses of antipsychotic medications for individuals who use tobacco or those who are on medications that might increase or decrease the hepatic metabolism of the antipsychotic. The side effects of the second generation antipsychotics still include the extrapyramidal or movement side effects, but they're not as frequent as what is seen with the first generation. QIN-QIO has a really great one-pager that has a complete list of all of the first and second generation antipsychotics. I don't know if somebody can put that link potentially in chat, it would be great. I would recommend that if you get that, you can print it off and keep that in your binder that you have at your facility. It's just a great reference so you can see which type of antipsychotic the resident is on. Next slide, please. So again, the main difference between the side effects profiles of the first and second generation is that the first generation have more neurological side effects and the second generation have more metabolic side effects. So monitoring really becomes important when we're prescribing these medications. The second generation antipsychotics are known to cause an increased overall risk of death, and this is presumed to be related to the elevated cardiovascular risks that we see that are associated with high cholesterol, the blood pressure, blood sugar, and weight gain. That being said, it's important to monitor for the above side effects with periodic blood work as well as periodic weights, blood pressures, and blood glucose levels. The movement disorders can and should be identified using the AIMS test. So next slide, please. So the Abnormal Involuntary Movement Scale, or AIMS, is an assessment which should be done at baseline so that you can monitor for any of these extrapyramidal or movement side effects. And they should really be done as a baseline for any resident that's starting on an antipsychotic. This assessment can be done by a prescriber or by a nurse supervisor. The AIMS aids really directly in early detection of tardive dyskinesia, as well as providing a method for ongoing surveillance and monitoring. Although the incidence of dyskinesia is relatively low in recent years, when you change prescribing, this may result in increased occurrence. So clinicians really need to be alert to these possibilities and employ tools that will help them pick up any developing problems as soon as possible. This simple checklist takes only about 10 minutes to complete and uses a 5-point rating scale for recording scores for 7 body areas. They look at the face, the lips, the jaw, tongue, upper extremities, lower extremities, and trunk. Also, we have to look at the monitoring more so with the second generation antipsychotic. So we're going to often do monitoring of blood pressure, weight, heart rhythm, and rate. We have to do cholesterols, lipids, eye exams, blood sugar, and then liver and kidney function monitoring as well. Sometimes the provider is going to check the blood levels of the antipsychotic to ensure that it's at a safe level and it's at an effective level. The provider also might ask routine interview questions to see if the resident is having any side effects or symptoms. The provider can lower or raise the dose based on some of these assessments, and they also want to, switch to a different medication based on the results of monitoring. Next slide, please. So this is a list of the most commonly prescribed antipsychotic meds in nursing homes. I got this from the NIH. I think it's still fairly relevant in what's being prescribed in the nursing home settings at this time. Next slide, please. So this is a great slide to get kind of like a quick check on this relative severity of the side effects of the different antipsychotics. So across the top, we're going to see comparisons made to the extrapyramidal or movement symptoms. We've got sedation, weight gain, hyperglycemia, anticholinergic side effects, and orthostatic hypotension. If you look at the lower left, we see that haloperidol, which is a first-generation agent, has the highest incidence of extrapyramidal effects, but interestingly is less sedating than some of the second-generation agents. That being said, it may not be your first choice of an antipsychotic for someone that has just been diagnosed with Parkinson's-induced psychoses. So we would want to look at something like quetiapine or olanzapine that have less of the extrapyramidal side effects. Because many of the medications will pose a risk for weight gain, we're going to want to monitor A1Cs to ensure that this weight gain doesn't lead to a cause of diabetes. Then we would have to certainly add a diabetes regimen as well. Monitoring for the orthostatic blood pressure is important to prevent falls. The orthostatic blood pressure monitoring could include 2 positions, lying and sitting or sitting and standing, and should be taken twice a day at the start of the medication and then once daily for a week and then every week. Monitoring and reviewing information with our psychiatric team is how we can make the right selections and do dose adjustments accordingly. If an antipsychotic must be used, I think this chart can be really helpful, not only in determining which one might be best for the individual resident, but also I think it's great for the care team to know, to have something like this on hand, because it actually will help to share like what types of side effects might be relevant in the individual. So we know how to plan with our care plan based on what side effects we might see with the antipsychotic that the resident has been put on. Next slide, please. So before determining if we're going to prescribe an antipsychotic, it's really important to assess the resident to ensure that any symptoms that they have are not due to a medical condition or another medication or perhaps or substance use disorder. So after a complete assessment of the resident, if we decide to put them on an antipsychotic, there are certain things that we must ensure. So we have to ensure that there's an appropriate diagnosis documented in their chart. We have to ensure that the resident's being monitored to ensure the medication is actually reducing the targeted behavior. We want to monitor the resident for side effects, and then we need to have a plan for gradual dose reductions as well, unless it's clinically contraindicated. iPro again has a great tool in our resource library. It's called a psychotropic review tool, and really gets down to the individual resident level. And it's great because it has a checklist of questions, including is there a diagnosis for schizophrenia, or does the resident have a diagnosis of dementia with behaviors? So it's really just a handy tool. Again, it goes down to the resident level that you can print off and have handy in the facility for a quick review. Next slide, please. Psychotropic drugs include the antipsychotics. They also include antidepressants, anxiolytics, sedatives, and hypnotics, as well as mood stabilizers. The medications that are listed under mood stabilizers are actually medications that are being used off-label. All of the above are used in the long-term care setting for specific conditions. However, there is overlap in their usage, meaning that they're all often used together, or they are sometimes substituted for one another, especially in residents with dementia-associated behaviors. Next slide, please. As mentioned earlier, once you decide to use an antipsychotic medication or any psychotropic, there needs to be a plan for gradual dose reduction unless it's clinically contraindicated. I'm not going to spend a lot of time on this because it's going to be covered in our next webinar, but I think it's important to understand that the purpose of doing dose reduction is to find the optimal dose, or to determine whether the continued use of the medication is benefiting the resident. If you do dose reduction, it should occur in modest increments over adequate periods of time to minimize withdrawal symptoms and to monitor any symptom recurrence. So really, it's really used to evaluate the resident's progress. And it's important, we want to be cautious because we want to make sure that as we do this, it's not affecting the resident. Next slide, please. It's important to closely watch the prescribing of both routine and PRN use of psychotropic medications, especially antipsychotics, both from a regulatory point of view and a resident quality of life point of view. According to CMS, any PRN order for a psychotropic medication can only be for up to 14 days. Any antipsychotic ordered as PRN may not exceed 14 days. Such an order could not be renewed without a reassessment of the resident, and it must be a direct examination of the resident. A PRN order for any other psychotropic can be continued for up to 30 days if the provider documents the reason and rationale. Next slide, please. There are alternatives to antipsychotic medications to manage individuals with dementia. That being said, medications, of course, should never be our first choice. Medications such as mood stabilizers like Depakote, again, that's being used off-label, can be an effective medication, but it also comes with risks of potential liver toxicity and low white blood cell count. So the individual should be monitored for this. And anxiolytics are also used to control some of the symptoms of dementia. But again, these medications will cause drowsiness and are best used only in the short term if possible. Trazodone, which is an antidepressant, has also been used as an alternative to antipsychotics. But again, this too causes sedation and carries the risk of oversedation and fall. So again, we need to be using caution when we use any of these alternatives as well. Next slide, please. So non-drug alternatives should always be considered first for individuals with dementia. Activities like group programs around special interests can be helpful. There's been great success with music therapy and other creative programs. Also, emotional reassurance, if an individual becomes agitated, can be very helpful as well. And iPro, again, has a great resource library to share with you some of these alternatives that you can use to or employ as a tool in the nursing home facility. Next slide, please. So iPro also has an action plan that can help provide you structure to review some of your current processes with regarding diagnoses and medications and other details that are necessary when using antipsychotics. So I would certainly advise you downloading that. We also, again, have the resident specific review tool that I mentioned earlier, another great resource. And we can also provide some support for you one-on-one to guide you through some of this, some of the steps of the action plan if you need to. So please reach out to our team if you need some help with that. Next slide, please. Some of the other resources we have to provide insight regarding programs that have been referred to as best practices for dementia care are Comfort Matters and Positive Approach to Care. So again, we have these links and this information is available for you. But I think, the driving message home, which I'm sure most of you are aware of, we don't want to use antipsychotics as our first choice. We try to use these, supportive measures as best we can, especially with our residents with dementia. And antipsychotics should be used only when we believe that they're our only resort. So thank you for your time. I think that's my last slide. Next slide. Thank you. And hopefully we can have time for a couple of questions.
Sure. So Margie, we first question that we had was, give me 1 second. Could you repeat the ortho BP schedule to use when starting a new antipsychotic?
Okay, so basically that is you can either do it for sitting, lying and sitting, or sitting and standing, and you would do that twice a day for the first week, and then weekly, and then you would do that every week, then just weekly. Let me just verify that because I want to make sure I'm giving you the right information. So it's lying or sitting and standing. And it is again, lying and sitting or sitting and standing, and should be done twice a day at the start, and then once daily for a week, and then every week.
Perfect. Thanks, Margie.
Yeah.
There was another question. There are new antipsychotic medications that come out regularly. Are any of them any better than the atypical agents that we normally use, such as Severity?
I mean, I think we're still going to see similar side effects from them. It all depends on the diagnosis and what our targeted behaviors are that we're trying to get at. So I think they're always coming out with, well, they're not always coming out with new medications, but I think we're going to see that because unless they come up with a different mechanism of action, so if they're going to come up with something that's not just hitting dopamine and serotonin, I think we're going to see similar side effects. They may just be different. So I think like that chart that I shared with you on the relativity of the side effects, I think that type of information is something very helpful when you're looking at drug selection based on targeted behaviors and then how we monitor for that over time.
Perfect. Thank you. Lynn, you can take us to the next slide, please. So before we close today's session, if you could put into chat if you thought today's program was a good use of your time, and if you thought that if there was something from today's program that you can use in your daily practice, it would be very much appreciated. The feedback does help us inform future content for you all. So I'll give everyone a chance to do that. And Lynn, if you could take us to the next slide. So while people are putting their responses into chat, if they thought today's session was valuable and if there's anything that they could take back and implement within their own facilities, we do have our contact information here that we'd like to share with you all. So feel free to reach out to us if you need any additional assistance in regards to quality improvement initiatives. If you have any questions, we're here to help support you. Perfect. Any last questions before we end the session for today?
Josh, is there somebody that has their hand up there? Laura?
I can't see.
Oh, she's gone. It must have been an error.
I think Laura said it was, she said, oops, it was
Yeah,
an
she-
accident. All right. Well, that'll be it for today's session. If you know anyone who would benefit from today's session who might have missed out, we are playing this recording again tomorrow at 3:30. So encourage them to come to our session then. And then we also have our IEP3 session this Thursday at 11 o'clock, the open office hours, infection control content. Couple of comments here where they can find the tool. So I did put a link into the chat for the iPro resource library. I will put it again into chat as well, just so you can through it. Pauline, as a comment, in my experience of 30 years in long-term care, mostly in dementia care, the anytime had adverse effects on the resident.
From gradual dose reduction.
See. Margie or Dr. Lynn McNichol, do you have any comments or feedback for Colleen for that comment?
So Colleen, when you're saying they've never rebounded when restarted from gradual dose reduction, is that what you're saying? Yes, maybe.
Lynn Smith, if you could unmute Dr. Lynn McNichol, that would be appreciated so that she could chime in.
Thank you, Colleen. Yeah. I will defer to Dr. Shapnube.
Josh, I don't see her on the list.
Lynn McNichol, she's an attendee. She's in as an attendee.
Oh, there we go.
She can't unmute herself. Oh, that's Colleen who can't.
She should be able to talk now, Lynn.
Oh, good afternoon, everyone. I think I'm unmuted. Can you hear me?
Yeah, we can hear you. You're a little fuzzy though.
Okay, let me try this. Is this better?
Yeah, but your volume is, I don't think, as much. I don't know if you could increase your volume. It was definitely clearer, but it was more faint.
Sorry, I can't really fix it. Let me talk loudly if I can. So
It's good.
I totally agree. It can be quite difficult to do GDRs, but it is worth doing. And sometimes you just have to wait a little while longer as the dementia progresses. Their need for the antipsychotic might go away as their dementia becomes more passive rather than very active. I'm sure you've seen that eventually they become less agitated at times. I'm not sure about how it can be more difficult once you put them back on the dose. I don't see that, but I can understand how that is possible. And what I would suggest is putting in place all the other measures that we've talked about over the series to help the team and the patient and the family avoid some of these expressions. So you can't just do the GDR without all the other implementations and figuring out a plan of care for the resident. But it can be quite complicated, I agree. So I think we have a session on that. Margie, is that correct?
Yeah, I believe it's our next session, I think.
So we can go
Exactly,
into
okay.
details, and happy if you can share an example, that'd be great. And we can use that case to use as our discussion point. I think that's it, Joshua.
All right, perfect. Well, thank you so much, everyone, for joining. That'll be it for today's session. We look forward to seeing you again soon. Thank you so much.